very much, sir, for the kind invitation. And at the outset, I'd like to thank the organizers, Dr. Rao, for. So I will be discussing about the management of Chyle leak following neck dissection. So before we actually talk about the management per se, so it's better to spend some time on the anatomy and the embryology of the thoracic duct. So as we all know, the predominant lymphatic drainage takes place through the thoracic duct, and it drains almost the entire human body except the right part of the head and neck and the superior hemithorax, which comes under the territory of the right lymphatic duct. So coming to the course of the thoracic duct, so it begins at the level of the cisterna chyli, which spans the distance between T10 to L3 vertebra and is formed by the confluence of the two lumbar lymph trunks. And it is important to note that only in 83% of the cases you will have a well-defined cisterna chyli. So the anatomy of the thoracic duct is prone to a lot of variations. So from the abdomen, where the thoracic duct is located to the right side of the vertebra, it enters into the thorax through the aortic aperture. And the cross-sectional anatomy over here is very important for surgeons who are doing the VATS-assisted ligation of the thoracic duct. So here you will find the thoracic duct located in the posterior mediastinum. It is placed between the azygos vein on the right side and the aorta on the left side. So it maintains this cross-sectional anatomy till the level of T5, after which it traverses to the left side. And when it does so, it lies posterior to the esophagus, and after that it enters the neck. So this is where it is very important for us head and neck surgeons. So whenever we are doing the dissection in the supraclavicular triangle, we have to be aware of the thoracic duct anatomy and also its associated variations. So here you will find the thoracic duct typically in this particular triangle, where it is bound anteriorly by the subclavian artery. Posteriorly it is bound by the scalene muscles and the longus colli. It is located medial and posterior to the carotid sheath structures, and it tends to form a loop while it tries to drain into the lymphovenous angle. So along the course of the thoracic duct, you will also have encountered numerous tributaries. For example, the intercostal lymph trunks, which drain the intercostal nodes, and the lumbar lymph trunks, which carry the lymphatic drainage from the aortic nodes. Unfortunately, the textbook description that we just saw is valid only for 50% of the cases, and there are innumerable anatomical variabilities that we will subsequently discuss. So the reason behind the increased amount of variability that we encounter lies in the embryology. So in the developing embryo, the lymphatic drainage basically originates from 6 lymph sacs. The 2 lymph sacs located in the jugular area, the 2 lymph sacs located in the iliac region, 1 retroperitoneal lymph sac, and the cisterna chyli. So various degrees of involution and joining of these lymphatic trunks actually gives rise to the final thoracic duct. So the final thoracic duct is formed by the persistence of the inferior part of the right-sided duct and the superior part of the left side duct and the intervening anastomotic segment. So persistence of the superior part of the right side duct can give rise to various abnormalities. So on rare occasions, you can find a duplication of the thoracic duct. That is, you will find a right and the left persistent duct. You can also have preferential drainage to the right side instead of the left side. And you can also have a straight left-sided thoracic duct where the right side duct is completely, it hasn't developed at all. Or you will have the entire lymphatic drainage taking place from the right side. So coming to the termination of the thoracic duct, so since this is the anatomy that we frequently encounter during the neck node dissection, so you can either have a single termination of the thoracic duct without any associated ductules, or you can have multiple ramifications which then join together and finally drain into the lymphovenous angle, or you can have multiple ductules draining separately into the venous structure. And also during cadaveric studies, it has been noted that the junction of the internal jugular vein and the subclavian vein is the most common area of the drainage of the thoracic duct. But you can also have drainage exclusively into the IJV, or into the subclavian vein, and sometimes even into the external jugular vein. So another important thing to note is that it is not restricted to the supraclavicular triangle. Sometimes the loop of your thoracic duct can go as high as 5 cm above the clavicle. So a bit about the physiology of the thoracic duct. So mainly the thoracic duct propels the chyle towards the venous structure. To do so, there are multiple valves in place. So the most important is the ostial type of valve, which is located at the lymphovenous angle. So in some cases where there is raised jugular venous pressure, you can have a distended appearing chyle duct. So there are multiple factors which actually affect the chyle flow. It is dependent upon the patient's nutritional status. So this is what we use to identify the thoracic duct leak intraoperatively, that is by giving a preoperative high fatty meal to the patient, because the flow is expected to increase when you load the patient preoperatively with a high fat diet. It also depends upon the intestinal function and changes in the intrathoracic and intra-abdominal pressure. So in brief about the right lymphatic duct, it is much shorter in course than the thoracic duct. It measures only 2 centimeters in length, and it is formed by the union of the right bronchomediastinal trunk, the right jugular, and the right subclavian trunk. So it is important to note that in the absence of any anatomical variation, the content is lymph and not chyle. So that is important when we talk about the right-sided lymphatic leaks. So coming to chyle leaks, it is actually a rare complication following neck dissection. It is seen in 2 to 8% of all neck dissections. But when you look at a high volume center, you will frequently encounter this complication. So as mentioned previously, it is not exclusively found on the left side. You can have as many as 25% of the chyle leaks occurring on the right side as well. And because the chyle is rich in electrolytes, protein and fat soluble vitamins and immunoglobulins. So when you have a persistent chylous fistula, it can really impact the postoperative course of the patient. It can result in electrolyte imbalance, protein loss, metabolic depletion, and chyle acts as a local site irritant. So it can actually cause a lot of inflammation in the postoperative tissue. It can give rise to the necrosis of the overlying skin and also precipitate surgical site infection. So the complication that we should be really afraid of is the development of chylothorax or chylomediastinum, because it is potentially life-threatening with 25 to 50% incidence of mortality. Coming to the predictors of postoperative chyle leak, so it basically occurs after dissection in the supraclavicular triangle, that is clearance of the level 4 or the level 6 lymph nodes. However, on reviewing the literature, there is no clear-cut correlation between the lymph nodal yield at level 4 or level 6 correlating with the incidence of chyle leak. However, it has been noted that the incidence is higher following endocrine surgery than non-endocrine surgery in the neck. And also the technique of dissection does seem to have a bearing on the incidence of postoperative chyle leak. For example, dissection with a harmonic scalpel, the incidence of postoperative chyle leak is seen to be higher because the harmonic scalpel tends to seal, and the lymphatic vessels, unlike the vein or the artery, they seem to lack the elastic fibers and they only have a single layer of endothelial cell. So the sealing property is not very effective with harmonic scalpel for lymphatic structures. So postoperative dissection, postoperative identification is mainly clinical. So it typically manifests after the enteral feed has been resumed. So you will have a sudden increase in the drain output. It will typically have a milky color, and you can also see a supraclavicular fullness. And if the chyle leak has been there for a very long time, the overlying skin starts showing signs of inflammation. You also need to monitor the patient for various sequelae like metabolic abnormalities, electrolyte disturbances, and also get a chest X-ray, because if you see a pleural effusion or air fluid level, it can either indicate that there is lower oncotic pressure or the patient has started to develop chylothorax. So in case you have equivocal clinical findings, you can resort to biochemical detection technique, that is, you can send the drain contents for analysis. So a lipid analysis of the drain content, if it is chylous, it would typically show a triglyceride value more than 100 grams per deciliter, or if you compare with the patient's serum, corresponding serum value, it will be higher than the serum value. Presence of chylomicron is not very much conclusive, and this is a point of care device where a small amount of aspirate can identify as well as quantify the amount of lipid. One important thing is that when you have right-sided lymphatic leak, you might not get the typical chylous character, and also your triglyceride values might not be very high. So in that case, you need to have a very high index of suspicion if you have a persistent high drain output and it is not explained by any other form of leak. So management of chyle leak is largely dependent upon the volume of chyle that is getting drained in 24 hours. So you can have a low volume chyle leak or a high volume chyle leak. So if you look at the literature, there is a lot of discordance about the cutoff to define this low volume and high volume leak. So if you look at the literature concerning head and neck, so they mainly mention cutoffs at 300 or 500 to 600 ml per 24 hours, whereas literature on VATS ligation or chyle duct embolization, they are quoting a very high cutoff to the range of 1000 ml per 24 hours. So the best strategy to avoid a chyle leak is intraoperative identification, and in case you have identified the chyle leak, you need to repair it. So there are various means to identify chyle leak intraoperatively, that is by giving a preoperative high fatty diet, and always examine the supraclavicular triangle after you have completed the dissection. Ask the anesthetist to give a Valsalva. You can also apply pressure over the abdomen, and then, as you saw in this case, you can see exudate of white milky material filling the supraclavicular area. It also helps to use loop magnification, because many times you will not be having a very high volume leak. You might have just endured a small duct tube. So in that case, using loop magnification might help you to identify very small leaks, and also giving the Valsalva maneuver. So once you have identified the leak, you need to repair it. Again, you can choose to use loop magnification. So for the repair, we prefer to use non-absorbable suture material, because the non-absorbable suture material will also produce a local site inflammation, which can also help to seal the leak. And we also use titanium clips. In case it was a very high volume intraoperative leak, after you have done a suture ligation, you can use either a vascularized muscle, you can rotate the sternocleidomastoid or the levator scapulae, or use the pectoralis major muscle to augment the repair. And in case you have access to fibrin glue also helps to seal the leak, but it is very expensive. Now coming to the management, as previously mentioned, depending upon the volume of chyle leak, low volume leaks are classically treated conservatively, and you need to intervene only when you have a high volume leak or there is a persistent fistula. So conservative management mainly centers around dietary modification, giving supraclavicular pressure, and various pharmacological agents. So the aim of your conservative management is to decrease the rate of production of chyle and to give rest to the fistula so that it heals on its own. So ways to reduce the production of chyle leak is to modify the diet and to reduce increases in intra-abdominal pressure, that is by restricting the activity, giving stool softeners. And strategies for dietary modification can either be a completely fat-free diet, or you can use medium chain triglyceride based diet. So basically MCT is a water soluble form of triglyceride. It doesn't enter the chylous system, it preferentially goes into the portal circulation and bypasses the thoracic duct. So while giving these treatments, it is also essential to take care of the patient's nutrition. So patient has to be supplemented with high protein, multivitamins, minerals, and also you need to correct any ongoing electrolyte imbalances. Also, the wound care should be going hand in hand because, as previously mentioned, these patients are very prone for surgical site infection and inflammation of the overlying skin flap. So, in case you have an open wound, there are some studies which show that negative pressure wound therapy might be of help. There are many centers which also consider total parenteral nutrition, especially when you have a very high volume leak. It completely bypasses the lymphatic system. So when you're prescribing total parenteral nutrition, you need to be very specific that it should be a fat-free TPN. You need to exclude the lipid component from the TPN while you're prescribing that. And also, unlike the MCT diet, this requires IV access and close monitoring for metabolic abnormalities. So, octreotide has basically revolutionized the management of postoperative chylous fistula. It is a long-acting analog of somatostatin. So, unlike somatostatin, which requires a prolonged infusion, octreotide can be given 8-hourly using subcutaneous dosing. So, the mechanism by which octreotide reduces or helps in the chyle leak is that it reduces pancreatic secretion and decreases the splanchnic blood flow. It needs to be used with caution in patients who have underlying cardiac disease or hepatic disorder. This is a meta-analysis and systematic review which compared injection octreotide with just oral dietary modification. Though the systematic review did not find any statistically significant difference between these two modalities, it is important to note that there was a lot of inconsistency in the way the two treatments were given because these were retrospective studies. So many patients received total parenteral nutrition along with octreotide. So based on this, we really can't say whether there is no benefit with octreotide at present. So the other agents which are not that frequently used, one is the pancreatic lipase inhibitor orlistat, which inactivates the pancreatic enzyme. The other is the adrenergic agonist, that is epinephrine. It is an alpha adrenergic sympathomimetic drug which causes smooth muscle contraction at the thoracic duct. It has been used in one study as an adjunct to octreotide. It, however, needs to be used very carefully and requires cardiac monitoring. Coming to the intervention, so once you have exhausted your conservative management and there is still a persistent fistula or there is a very high volume leak, then you need to go back in and intervene. So about repeat neck exploration, so it is very technically challenging because once chyle leak has set in, there will be so much inflammation that it will be difficult to go back and locate the leak. And in case you are able to identify the leak, you need to take some additional measures like use muscle flaps to further augment the repair and use tissue sealants. A word about sclerosins. So there are studies where sclerosins have been injected by the percutaneous route or through the drain tubing. So the agents which have been used are OK432, intralesional tetracycline or glues. The problem with these agents is that again they induce a lot of fibrosis and obliteration. It basically makes it very difficult for you to do any further surgical intervention in the future, and also there is a theoretical risk of causing injury to the phrenic nerve and the internal jugular vein. So in case of very high output leak, so VATS thoracoscopic ligation is what is preferred nowadays. So the right thoracoscopic approach is selected and the anatomy which we had talked about in the beginning in the posterior mediastinum, that is utilized for the ligation. So there are certain visual agents which can be used to identify the leak. For example, one can use fluorescein or indocyanine green and near infrared imaging. About thoracic duct cannulation and embolization, so this can be an alternative to VATS, but it requires a very good support from the interventional radiologist and it is technically challenging. So a prerequisite before embarking upon these procedures is to do a MR lymphography because of the wide variation in anatomy that we know of. And the approach selected for doing a lymphography and embolization, one can either isolate a lymphatic vessel in the web space of the toe or go through the inguinal lymph node, identify and inject the ethiodized dye and take a fluoroscopic image after that. And once the cisterna chyli has been identified on fluoroscopy, a guide wire is passed trans-abdominally from the right hand side to cannulate the cisterna chyli. And once the and then the contrast is given, and once you have seen the area of contrast extravasation, embolization can be undertaken either with the help of coil or glue. So in centers which deal with this kind of an intervention very frequently, they have reported a success rate upwards of 75%. So in case even VATS and embolization fail, so these are last resort measures. One can consider surgical pleurodesis or a pleuroperitoneal shunt. And a bit about our own experience. So in our experience over the last 4 years, we have identified a 4.8% incidence of chyle leak, of which 21 chyle leaks out of 62 were identified on the right side. Fortunately, we did not have any chyle leak in the range of 1000 ml per 24 hours. And we did send drain triglyceride value for all patients, and it is interesting to note that low drain TG levels were seen in 62% of the right-sided leak and 58% of the left-sided leaks. And we tend to give medium chain triglyceride along with injection octreotide, and we compared the time taken for the chyle leak resolution with another group which was given total parenteral nutrition, and we did not find any statistically significant difference. We again looked at the subgroup with high output leak more than 300 ml per 24 hours. Again, we did not find any difference between MCT octreotide versus TPN octreotide. And finally, to conclude, so the anatomical course of thoracic duct has many variabilities, and you can also have lymphatic leak or chyle leak on the right side. And the best strategy is to intraoperatively identify these leaks and repair it. Even after doing so, you still might have postoperative chyle leaks. So management is mainly conservative in case of low output leaks, and various interventions like VATS or embolization is reserved when you have a persistent leak or a very high volume leak.
Thank you. This excellent talk on a common complication that we have seen. Any questions?
I have basically two questions. Do you have any to shift the patient from RT feed to TPN? Do you wait for a clinical sign or do you wait for a biochemical change?
No, we don't wait for a biochemical change. So once
you wait for the anasarca to be visible, or you wait for the sodium or albumin to lower down.
Sorry,
so what is your threshold to start TPN in chylous patients, chylic patients?
So if you have a very high output leak, for example, between 300 to 600 ml, so in those cases, we tend to prefer total parenteral nutrition and keeping the patient nil per oral and only giving RT feed which doesn't contain any fat. So it's not exactly a complete nil per oral. We do allow
MCFA diet.
a completely fat-free diet and a fat-free TPN. So when you have a moderate amount of leak that is between 300 to 600 ml, that's when we prefer to completely bypass the lymphatic system and keep the patient.
So it depends on the drain quantity. If it's a high output chyle leak.
Yes. It's the volume of the drain rather than the TG value.
And second, does the chyle has the ability to, macerate the tissues, or especially after total laryngectomy with the primary closure? If there is a chyle leak, post-operative chyle leak, you identified a chyle leak. Now, all your great vessels are exposed to the chyle. So, are we worried about the blowout?
Yes, we have
that situation is good. Yeah, exactly.
We had
So,
one patient of blowout in
what
a
do you do in those
post-total
situations? Do we go back and because you don't want to go back and because the larynx erosion is there. So that situation is a little tough situation. So how do you go about it?
So if you have detected it very early on, and I think during that window you can still go back in and intervene rather than to wait for the intervention to become very extensive, because during that time identification of the leak is also very difficult.
So basically it macerates the tissue and it can...
Yes.
And ma'am, the talk was good. I wanted to ask, if we've done a free flap and same side there is a chyle leak, should we be worried about it?
ಆಪರೇಷನ್ ಕೊಡ್ತಾರೆ ಈಗ
If you've done a free flap reconstruction, but still we would keep the patient on conservative management for the sake of chyle leak. We have not gone back in and intervened surgically. I don't know about the practice in other centers.
I don't think. Sorry, go ahead. I don't think chyle leak will be a problem for free flap reconstruction. So the management of free flap should continue for its own merit. Look for any congestion or all those things, and if required, we need to re-explore. And I don't think the chyle leak can become so engorged to produce compression of the anastomosis.
I think just a comment that earlier you go in and control the chyle leak, it's always better. So if you have a persistent chyle leak more than 300, 600, and as it's going up, the longer you wait, more chance of maceration of tissue and all. And even when there is a free flap in place, our threshold for exploration is very low. So even if I have a very high chyle output, I would rather go in just immediately rather than wait for a long-term period. When we analyze our chyle in around 8,500 neck dissections, we saw that there were about 120. And the ones that we went in and operated and ligated immediately, the average length of stay was reduced. So the longer you wait, the patient is going to get malnourished, and you will have to sit on the patient for longer. Octreotide and all is known to help, but I don't have much experience with octreotide.
Ma'am, your talk was very good. Regarding parenteral nutrition, we need not give fat-free parenteral nutrition because it bypasses the lymphatics there. So we can give total parenteral nutrition, which includes lipids also. That when we are giving enteral nutrition, we have to give MCT or a fat-free enteral nutrition. But when we are giving parenteral nutrition, it's not required to give total fat-free parenteral nutrition.
Actually, in few of our patients, when we were giving the TPN, the volume was not reducing. Then we started excluding the lipid chamber.
But the lipid doesn't go to the lymphatics; it is metabolized in the bloodstream itself.
Sir, regarding octreotide, we have a trial running where they are comparing octreotide versus diet. In a high volume setting, octreotide won't work. If you have an output of about liter or more than 500 ml, no matter what amount of octreotide you give, it is not going to stop. So your idea you should re-explore as early as possible. Don't wait for the tissue to get macerated because the closure becomes difficult. And Pfizer has a technique of closure actually. Most of his residents use that technique, and it's a very good technique actually. Can you describe it?
Yeah. I was about to ask you the same, sir.
It's not about the technique, it's all about the position. Like you showed the anatomy very well. It's where the chyle duct crosses over from the left side behind the carotid and then comes on to the subclavian. So in case we are able to not identify it, we would be able to just elevate the carotid sheath and then suture it to the prevertebral. So in order to cause a compression on the duct where it has crossed behind the carotid, that's where we would just elevate the carotid sheath and suture. My take on this was that when you have a high output leak, you might also want to consider an intervention method wherein they would just do a lymphatic obstruction, identifying one of the lymph nodes and injecting a glue in that, and that causes the obstruction of the entire cisterna chyli.
Ma'am, in your talk, I never came across a word called as compression dressing. Is there a role of compression dressing in chyle leak? If so, when would you do it?
Actually, it's a bit controversial, especially if you have a flap, pedicled or microvascular. So we don't give a compression dressing in those cases. So we don't use it routinely in our practice.
Yeah, I guess I think that's very vital that you don't. It's not going to help.
Yes.
Compression is not going to help cause a pressure on the chyle duct itself.
Yeah.
So, if you don't have a flap, you may try it as part of your conservative treatment. But in the presence of a flap, it's better avoided. So, and one point I wanted to make about the TPN is that using TPN itself has its own problems. So it should not be used as an alternative. It should not be used in a regular fashion. At least at our center, we don't use TPN for Chyle leaks. We have never used it. So, because it has its own problem. So, when a patient has Chyle leak, you have to regularly monitor the patient's weight and the counts, at least on a weekly basis. And then intervene, as what Sir said. If the Chyle output is high, we tend to surgically intervene. We do all conservative approaches, including the use of octreotide. Of late, we have started using octreotide. It does work in some patients, but it's difficult to say in whom it works and whom it doesn't. And it's not guaranteed that it's going to work in all. So you just need to try all conservative and then surgery. And you have to explore the neck. You shouldn't, of course, there's going to be inflammation and all that, but you should try the neck. If that doesn't work, then you use the VATS ligation. And even if that doesn't work, then only we try something else. So that is the sequence. And in all these, and if the Chyle leak output is very high, despite all your efforts, is when we use TPN. Because you need to, manage the nutrition of the patient. But be aware that using TPN also has its own issues.
Also, the main reason why I told about dressing is that we need to understand the location of Chyle duct, as Madam explained beautifully. So it lies deep in the neck and just adjacent to the carotid sheath. We need to understand that the pressure dressing will be more superficial. We'll never be able to reach that amount of compression which would externally compress the Chyle duct so that the leak would come down. The reason why I brought this point is because we have all sets of head and neck surgeons who are listening to this with various experiences. So we need to iterate that what is the step ladder management of Chyle leak and where we need to intervene. Sir, I have a question, and also ma'am. So when we go and open up the neck for re-exploration, many of the times we find that the tissues are very friable. So how would you, number one, identify the Chyle, where the Chyle duct is? So which what would you use? Would you use a clip, or would you use an en masse ligation, or you do identify the particular Chyle duct, hold it, because it's very difficult to hold the tissue over there. How would you repair it?
So if you're able to identify, that is the best case scenario rather than directly going in for en masse ligation. But again, if you're not able to identify it, that's when we'll start taking running sutures and then augmenting it with the vascularized muscle. You can use fibrin glue also in that setting.
I agree with you.
I think Dr. Karthi, the pressure dressing is the basic method of management of this patient. See, I encountered this type of cases since several years. The first in low volume lymphatic drainage. In these cases, definitely pressure affects. See, we used to put a bolus type of pressure in the supraclavicular area and used to strap with a dynaplast. Definitely it is useful. I can't say that pressure dressing is not useful.
Yes, sir. I think
because we were using these methods over several years and we could able to achieve it. I think
this pressure dressing this one controversy will always remain. You can never put the pressure dressing at the point where you want. The leak is almost behind the clavicle. Now you can't put the pressure dressing there. And when you don't put the pressure dressing at the point where it is leaking, the flap will become stretched out and it will come under, fluid will accumulate under the flap, and you will have a big bulge in the neck because you have raised the flap. I think the best thing is to have a good suction drain and then see where the leak is. As Professor said, go in and ligate the duct en masse probably if possible, or take the tissues around it and do multiple ligature, and then try for some time, keep a gas piece, wait, do a Valsalva maneuver, make sure that there is no more leak, and then only you can go home. This will be a problem. This is a major problem. We have used this pressure dressing, but unfortunately it has never worked. Either it has stopped on its own, because of the pressure, because of the drain, or we have ligated it. Once or twice we have tried of embolization, and we did the intervention, radiology consultation and all that. As we were planning, automatically the leak stopped and we kept quiet. We didn't have to use that. But I think this putting pressure dressing blindly anywhere is not a good idea. It is, sometimes it works, but there is no, I think we should do a control study if we want to do that, because there is no justification or rationale to put a pressure dressing blindly like that. That's my personal opinion.
So I take it from where the presentation where KK showed the vertebral artery, and doing this blind closure there puts all these at risk. So when you are exploring, my submission would be to identify the IJV and subclavian junction. More importantly, identify the phrenic nerve, because that is at risk, and identify the transverse cervical artery. So these are three important structures that we need to identify before you go ahead and try and see where is the chyle duct that's leaking. If you are able to identify these three structures, now you are safe enough to go ahead and take your sutures. If you have identified the chyle, of course you will ligate it and bury it with the fascia. If you're not able to identify, then there are methods where either you use a omohyoid muscle or you use a sternocleidomastoid muscle and pack that area. But most important, identify and preserve these three structures.
Any experience regarding the use of this surgical after repair? Like, do you use the surgical to cover the repair area?
Surgical, and if it's a high output leak, we also use the fibrin glue.
Sir, actually, there have been few case reports which have come out, very controversial, but I wanted to take the take by the senior speakers here. So, is there any role of injecting sclerosant, or tetracycline injection has been shown to have some effect in causing sclerosant in a refractory leak, despite of repair? Patient is having that. So, is there any take on the senior surgeons, and ma'am, do you have any say on that?
We had to do it in one of our patients because we had exhausted all possible means. Of course, we didn't go in for the wax ligation, but in that it did stop the leak, but then it caused a lot of inflammation on the overlying skin. We used intralesional tetracycline in that case.
I think using these sclerosing agents in that area is going to be risky, for sure. I think, at least for us, the last resort when nothing has worked is to do a wax ligation, and that has worked all the time. And the other point I wanted to make was, when you're giving a compression dressing here, and if the chyle stops leaking, we shouldn't be happy always. What might have happened is it might have gone into the thorax. So we shouldn't be happy that the chyle has stopped with all of this. Just take a chest X-ray and rule out that it's not getting collected in the thorax.
As Sir rightly mentioned, is there any difference when you try to clip the whatever the thoracic duct ligament you see? Is there any difference when you clip it and you ligate it with the suture? Are we expecting a distal ligation to the?
See, there's no randomized evidence to this. It's personal preference most of the time. I personally prefer to ligate. For one logical reason that I think is logical is that it tends to induce fibrosis, and most of our residents are so used to using clips that this just clips all around the place. And the problem with that, it's not with applying the clips, that's the way it's applied. It's rather than applying, it's just thrown around the place. That's how it appears. Rather, if you ligate it, might be better. So I personally prefer to ligate it and use minimal clips wherever it is essential, rather than just indiscriminately applying clips. Because when you have to go back and if there is a leak again, it becomes difficult to work around that place. So I would personally prefer ligate.
Dr. Smriti, what about interventional radiology? Wherein, for example, for interventional radiology, wherein you can inject glue directly into that area after seeing it with the fluorescein, finding out the site of leak. Like, for example, if they want to decrease the vascularity of a carotid body tumor, our IR in our hospital say that they can infiltrate some glue into it, so it will decrease the vascularity. I don't know whether it works or not. So
I don't have any experience, but the papers that I reviewed and I showed in my presentation, so they are basically going in either through the web space in the toe, or they are going through a lymph node in the inguinal region. Then they are injecting a lithiodized oil, doing a fluoroscopy, identifying the cisterna chyli, and then percutaneous through the abdomen, they are pushing in the guide wire into the cisterna chyli. So it requires a lot of expertise, and you need to get a MR lymphography before that to actually see that if there are any important anatomical variations. And they have used microcoils and glue for the final embolization once they've seen that exactly where the site of leak is.
Krishna Prasad had a comment, sir.
I usually, on table you have injured the thoracic duct, and you clipped it, and you are sure that it is not leaking. In that scenario, better keep the drain away from the thoracic duct. That's my advice. So again, this negative section will create again. So always I say, whenever you are done it, keep it with the drain away from it.
Thank you very much. So what we can understand out of this is the best way to manage a chylic is prevent chylic. Thank you.